I do like in one of your con-eds you also spoke to asthma and the fact that us giving the Solumedrol helps the patient so much more down the road. And I feel like a lot of times we're reluctant to give it to the peds. I don't know if it's a dose thing or... I don't think I've ever even
seen it given to peds. I don't think I've seen Solumedrol given to peds. Yeah, dual nebs, yes. And I haven't seen Solumedrol given to peds. And I don't know the reason for that, because definitely it will help them, down the line. Sure. You want to do early administration of a corticosteroid, especially like in a severe asthmatic, definitely, helps, with the clinical picture down the line. But I don't know why that is. And you brought up a good point about the MDI. I just want to make sure. We get cases. I had a case once that I brought up, and it was like, this kid went to a home. The kid had asthma, had worker breathing, and the dad said, we've tried, giving albuterol, like we've given it every hour, and it's just not working. Yeah. We're giving it every hour. It's not working.
Yeah, what was the expiration?
Exactly. So the question is, you're thinking, okay, well, I'm taking this kid. They've been giving it every hour. Should I give it? Like, is this really asthma? Or you listen to the kid, you don't hear any breath sounds. You hear nothing. But the kid is having difficulty talking to you in full sentences, working to breathe. It's an older child. And you're like, do I give it? Is something else going on? And the question is, do you give albuterol? Do you give the ipratropium? Do you give the... I would. Is the MDI expired? They really do. These are things, to think about and not just say, well...
Or are they even using it correctly?
Are they even using it correctly? Exactly.
Yeah. Like, do they have a space? Let's do a younger... Let's do a younger child. Do they have a spacer? So, like, personal case, my son... whenever he would get sick, he was diagnosed with reactive airway disease when he was little. So, and my pediatrician
you're also familiar with that thing.
Is Brian Zach. So, big shout out to him. Brian is phenomenal pediatrician. I love him to death. And it's like, we only used an inhaler for him when he got like a really bad respiratory. Sure. That was it. My son doesn't need an inhaler day to day. He doesn't have asthma, and then they're in that early stage where they don't want to diagnose them with asthma yet because they essentially too early. We don't know yet. And then now he's, knock on wood, he's fine. He doesn't need it. But you have those lulls in between them where kids aren't going to immediately get sick and then immediately get sick again when your meter dose inhaler is still within date, right? You have to look at that. And I think that's something we could probably improve upon is, what's mom or dad doing at home, or what's this caregiver doing at home with peds and adults, let's face it, because medications are not cheap these days. So if what they're doing is not working, is the date right? Is the date correct? How well did they take care of that medication? Right. Did they leave this EpiPen or meter dose inhaler in their truck for the past week when it's been 90 degrees outside? True. So what's the effectiveness of that medication? And I think some people are scared to then, I don't want to say redose in their mind, maybe like, well, dad's already done this. I don't want to give another one. I'll make him too tachycardic.
We've talked about that, right?
It's just, yes.
Yeah, they're tachycardic because they can't breathe, so we need the medication.
IMEP and not give any albuterol. Do I just do that?
And I'm pretty sure I've said this before, but remember, even if you give the albuterol and then you hear wheezes, it's probably because you loosen them up now that you can hear the wheezes.
Exactly.
So give more.
You want to give more, exactly.
And I think people get worried about that too. I'm making it worse. No, you're making it better.
You're making it better because now they're opening up. Now you can hear wheezes, like there's some air passing through those bronchioles. You can actually hear something. It's just how tight they were, so you couldn't hear anything.
Yeah, that's a good point. People think, I give this drug, it goes away.
No, you might
go away.
Might be slowly getting there.
Yes.
Right. With enough of it over enough time. Right. But that brings up the flip side of that whole situation, right? Which is, now they're wheezing because I'm making them better. But what if I bomb them with an aerosol or two and nothing happens, right? Either because they're completely just well acclimated to the drug, they've taken so much of it, or they're just not moving enough air that they're not getting there. Maybe we should attack by another route. Anything else that would be useful in this case?
IMEP.
We do the we'll hit them with that. And what if they're like a moderate responder to that? That's going to work a little better than the inhale, but how about MAG in these kids?
You can do MAG. Yeah. You can do MAG 50 per kilo with a max of 2 grams. Yes, you can do MAG. Definitely. Yeah. MAG helps also with vasodilatation. Yes, you can do MAG. Solumedrol, definitely, because that Solumedrol, like I said, it's not immediate. It works down the line, but it definitely, by the time these kids get to us, it's helpful. So I think just kind of, I always say, like, just throwing the kitchen sink at them. For the severe ones, obviously, like what you're describing, who, can't hear much and they're really, really having difficulty, or they're starting to tire out on you. Yeah. Those are the ones you kind of, you worry about. You want to do, I would continue doing, I can't say this enough. I really would support giving your beta-2 agonists your albuterol. Make sure you give them all three. Like, if you're supposed to give them all three, do them all three. Do that. Then you can definitely adjunct with your MAG, your Solu-Medrol. You want to give them, because if they've been getting so much albuterol, you want to just kind of give them some fluid for, insensible losses, excuse me. Sure. So you want to give them a bolus too. So these are the kids I would definitely put an IV in, give them some fluids as well. Yeah.
That was another point I wanted to make, is what role does the fluid bolus play in these, specifically these asthmatic kids?
They're working really hard. So yeah, I mean,
just stand outside one day when it's cold and look at your breath.
We're losing moisture here, right. and that's to your insensible loss. I mean, that's what that means. Is there's right. we can't measure that, right? But we have to account for that. And then let's polish your response on the MAG just a little bit. Because it seems like, certainly in my experience, like every medical director has a slightly different take on where MAG fits in, right? How early or how late. Let's just, from your eyes, if we had a really bad case where we've hit them with a couple of, we've got, maybe on our second aerosol, we've already had to stab the kid with some IM epi because just that bad, right? Do you want us to? Would you expect us to wait out that epi and that aerosol and then progress to MAG, or would you be okay with us be like, no, this is bad enough? Clinical course is set. Let's start the MAG now.
I think clinical course is set if that's what we're doing. So we have what we call like a clinical asthma score. We talked about that, kind of like making sure that it's parallel inpatient as it is in the pre-hospital setting. So if it is what we're talking about, like this is severe. So we have a score from like 1 to maybe like 8, and this is probably like a 7 and up. And like our algorithm would say give MAG right away. Like you would want to like give MAG, you'd want to give your Solu-Medrol, you'd want to give your bolus. Fair. Like after giving the albuterol and giving the IM-epi, you'd want to do MAG as well.
So again, we gotta bundle this up for 2:00 in the morning when I'm tired, I'm hungry, I gotta pee, patient's trying to die. Safe to say that if I have to go to IM-epi on a kid, MAG is, after we get that IM-epi on, it's
in the treatment path.
It's part of my package. I should be
delivering.
It's part
of your package. Yes, I should be thinking. The protocol.
It is.
That's a good way to put it. I like that.
I like that. Yeah, that it comes together. It's all together in a package.
Even though it's all teased out and stuff is grouped together, a lot. Again, little medical directors have little different takes on how things should get bundled and where the priority is. And I just want to hear your.
I would say if they're severe, yes.
Okay.
If I got that severe. Yes. If it was kind of like moderate, and we have this scale of you moderate, and you've given like the 3, and like they're moving air, they're able to speak to you in full sentences, you can hear breath sounds, retractions are better, work of breathing has improved, then I don't think you need to, go down that path. MAG. Yes, and do MAG and all that.
But it's fair to say that if they're sick enough for epi, they're sick enough for MAG.
If they're sick enough for that, they can't even and kids, especially the older ones, like they can talk to you, but even if a little one who's like tiring out, right, that tells you that they're really, they're really working. Yeah.
I like that to help make the decision for the pre-hospital providers. It's a good perspective.
Yeah, we try to bundle that stuff up, but again, we're trying to write the protocol for every medical director.
Very broad spectrum sometimes.
Yeah, it's but again, it's nice to hear from
specialty.
From the specialty, like exactly where that falls in your mindset. So let's talk about abnormal cases with families, right? So what things should we be looking for as concerning, right? So real quick, I remember we got called for a kid seizing one time. Went in, mom's passed out asleep, right? And the kids are just running around running around the living room and then sees us when we walk in and like runs and jumps into my arm. I'm like,
oh boy,
this is all kinds of weird, right? There is,
there's
but
no adult supervision.
this is this is very, very bizarre from the get go, right? So what kind of things like that are absolute red flags and send you to do more from social services and that perspective, abuse, neglect, evaluations and whatnot?
I always say, as a pre-hospital providers, you guys are the ones like on the scene, right? You guys are eyes basically because we're not there.
Right.
So there are certain things that we kind of look for. I always say it's not a bad idea to talk to us with any concern. Our job is to protect the child. You are not doing anything wrong by just voicing your concerns and just saying like, will I be liable for anything? Like, what if nothing is wrong here and I, maybe it's not true or something?
Right.
Will I be in trouble or am I? No. That's not our job. If we see something that's concerning, speak to whoever the ER physician or the social worker in the ED. Let us take it from there. What we usually do is we take it up with Child Protective Services. If we do, if there are findings that we see on the child or on the siblings that concern us, then that changes everything. Sometimes, if we are not seeing anything, the kid looks nutritionally well, we're not seeing any bruising, there's nothing there. The kid is not acting abnormal, we still bring it up with Child Protective Services because what is their job? Their job is to investigate.
Of course. Right.
But we've done our part, right? We've done our part. So there's I'll give you an example. EMS workers went to a home. It was like a party and there was like a domestic disturbance or something. And the pre-hospital provider said she walked in and she just didn't. Not only were there a few people in there, she just didn't like the setting. Like furniture was everywhere, and she saw one kid, and the people were yelling at each other. And something said, she said, "Let me just walk down the hall." She said it was an open space. It wasn't like she was going somewhere where they couldn't see her.
Yeah.
She was right there, so everybody could see her. She walked there, and then there was this little kid there in the corner. And the kid walked up to her and just hugged her and she said, "I'm so happy to see you." Yeah. Now, this kid was covered in welts and had been beaten because mom was drunk. And so she would just beat her with like a belt. So was she healthy? Yes. Did she have some bruises? Yes, but what they were originally called for was not for this child. They were called for something. I think a chair had been thrown at someone or something, so they had called. But she brought the kid in. She told the mom, she said, "I'm bringing this kid in." She called medical control.
Yeah.
Medical control was aware, and medical control, I think there was police around. She called police came. So the conversation was made, and I believe mom was drunk. So brought this kid in, and it turned into like a whole investigation. This kid had to be seen. So there's certain things, like if you are visualizing like illicit drugs that shouldn't be there, any signs of neglect. Now, I always say there's a difference between poverty and neglect, and that's something we do see in even for me when I did my EMS rotations, that when I did my ride-alongs, I saw a lot where I was like, wow, this is Cleveland. Like, I didn't know this existed, where you have people living in the same room and sleeping on the same mattress.
Right.
But is that abuse? No. Is that child neglect? No. That's just plain poverty.
Right.
So, but if the kid is covered in bruises, they look malnutritioned, or you witness something that just doesn't sit right with you. You witness abuse. Maybe a kid was being punched or they were hit, or you see bruising on them, and then the biggest one is a kid disclosing something to you. And sometimes kids do that. They see a stranger and they need help. So, and we have
spontaneously say something.
They say something. Please take it seriously and don't think this is none of my business. That's not why I'm here. If you have concerns, call med control, and we will talk you through it if we need to have the police involvement. Because sometimes in these cases, we need to get like permission from a parent to come in, because it's not, we can't just take the child.
Can't kidnap the child,
Exactly.
Yeah,
That's a good way of saying it. Can't just kidnap the child. And we have cases like that. We had one of the cases we run with our fellows is is very interesting. It's kids were in an MVA and EMS got to the scene, and the father's a physician. I said, I'm not taking them to the ER. I'm not taking them to be seen. But one of the kids, the EMS worker, pokes his head into the window and is like, "Are you okay?" And he's like, "I can't feel my legs." But the dad is like, "No, I'm a surgeon. I'm telling you, they're fine. You're not taking them to the ED." So what do you do in situations like that? It can get very precarious.
Right, yeah.
Call med control, call the police,
Yeah.
So it can be very precarious. And then we do have the ones now that we are seeing. Thank you for bringing this up, because I need to bring this up too. This is one that we're seeing a lot too. So suicidal ideations. Kids going on social media.
Yeah.
It's a cry for help and saying, "I want to kill myself, or I'm going to take pills tonight." A friend sees it and calls 911 and says, "My friend wants to kill themselves."
Kill herself, yeah.
Then the parents like, "No, you're not taking them. They're fine. You're not taking them to the ER."
Right.
What do you do in a situation like that? And a lot of times, like, the parent has the right to do that. So we try to work with the parents and to explain, like, listen, like, we understand that they may be fine, but our job is to just make sure they're okay.
Yeah.
And hopefully they may be able to come back home.
Let us do the assessment.
Let us do
right.
the assessment. Yeah. And we see that all the time now. All the time. Yeah. Or the child says, "I took pills." And the parents are like, "No, they didn't take anything." And then you're like, "Oh, yeah."
Yeah.
So.
Do they really know, right?
I think a good relationship between, like, police department and fire department help there too.
Oh, definitely.
I think
Most
kind
definitely.
of piggyback on everything you said, so that when you walk into a home and you see the red flag, it's very easy to just say, "Hey, go ahead and send me one of our police units." And then they show up, and then usually the parents are like, "Why did you call them?" And it's like, "Oh, they go on a lot of ambulance calls with us. They come with us all the time." I say that all the time.
Well,
they come on every call.
What took you so long to get here? Yeah.
They usually they just pop in and make sure we're okay, and it's like, "By the way, I saw this," and then it helps with that child because they can help you immediately remove that child from the home, working with Med Command and stuff. So I think it's very important that fire department and police department have a good working relationship, especially for those very unfortunate situations, because it's about the child.
Yeah.
Of course.
And aggressive patients too, which we do see. Aggressive patients, behavioral disturbances as well. Those are also difficult to maneuver, Those are also very difficult to maneuver. Yeah. Those are difficult ones.
And what about sign-offs? How are you with sign-offs of a pediatric patient when the parent isn't there per se? Let's say it's the 16-year-old that's driving and she gets into a fender bender.
Yeah.
And so we call and say, "Hey, doc, parent's not here. The parent's giving me permission over the phone. Are you okay with this?"
Yeah, we are.
So, and I think a lot of times people don't understand that. They think it's under 18, you're going. And it's like we have to understand that they have rights.
Yes, they do.
Even though that they're not of adult age yet, but they still have their rights.
They do,
So,
yeah. They call us and the moment they get in, we do everything we can to notify the parents as well, their guardians. Yeah, we notify them unless it's like a true emergency and we need to like intervene right away.
Correct.
Obviously, then we do everything we can to notify the parent. Kind of go from there.
Yeah, but to your point, that mid-teenage
Yes.
is the hard one to deal with, right? Because you may, especially when you have conflict between the kid and the parents,
The
right?
parents.
That never happens.
Never happens.
Especially when there's a car accident. Just kidding.
Did I say mid-teens? I meant mid-40s.
Still happens. No, but I think that's a huge point. And we all need to circle back to abuse, neglect. We are going to these people's homes, and we have a legal obligation to report that. We have a legal obligation as EMS to bring that up and say what we saw, and then let the emergency room take it from there.
Let's take it from there, right?
And with that too, your documentation is key. Don't insert your opinion into that. Just we found a child with bruising over different portions of the body in different stages of healing. Not your opinion. Like you can't say, "I believe this child is abused." Just right? Am I right there?
You're
in saying
absolutely
that?
right. You're absolutely right. Yes. You're absolutely right.
Objective
Documentation,
observation.
objective
Yeah.
observation. Yeah.
Here's what I saw. Yep.
And this is
This is it.
This is it. Mm-hmm.
So we're getting towards the end here, but the kind of last thing you touched on a little bit, we started talking a little bit about equipment specific to pediatrics, and I guess the one thing that I really want to push here and make sure that message is clear is weight appropriate restraint in the back of the ambulance, right? So the day is long gone where it's appropriate to, throw kid, put the adult straps on them, or put mom or dad on. You hold on. They are not crash rated parents. I've yet to come across one that is good for 20 G's. So.
And every squad, I just
20
want to
G's,
confirm.
but not 20 G's, right?
And I want to confirm that every squad has weight appropriate restraints, right? They all do in their ambulances, and that's key.
Whether that's a hard plastic car seat or
we have them
That's
though.
key.
Yeah. A lot of them have the fold down seats that have them built in.
Right, and those are what I've seen.
And you got to be careful. You bring up an interesting point that if we elect to transport the child in their car seat, which I usually like to do because it's theirs, check the expiration on it. A lot of people don't realize car seats expire, and there are safety factors built in. And I've seen them that that was my great grandma's, and it's like it's wooden.
What?
I got it at a garage sale. Yeah.
Not a good hand me down.
And I don't think technically they're supposed to sell them.
I believe that's
You'd be
correct.
surprised. Yeah, they're not supposed to.
I know I've
but
absolutely
they
seen them at
do.
garage sales.
Yes, I know they do.
We do a lot of education on car accident scenes with that because, I mean, insurance companies will replace your car seat a lot of times if you have that conversation because, correct me if I'm wrong, if the child is in a car seat and that vehicle is in a car accident, then most manufacturers are going to say that car seat is no longer deemed safe.
Correct.
Yeah.
You should replace it and stuff. And a lot of the general public doesn't know that. A lot they're like, it wasn't that bad. It's okay.
I can reuse
The fender
it.
bender.
I can
no longer-
reuse it. And it's
We
like,
actually don't give it back to them in our ER. We give them another car seat. So it's we have a car seat program, but
I've brought
good
car
point.
seats
That's
in
awesome.
from car accidents that we haven't even put the kid in again. We used something else, but just to show the physician this is the impact or this is what it looked like, and it tells a lot. It's
it
like
tells
helmets.
a lot. Oh yeah,
so.
definitely. Pictures help. Yes.
Yeah.
Yeah, pictures or props.
help.
We're props.
Yeah, right.
Pictures help. Yeah.
You
pictures
can
help,
you can deduce the energy transfer
Right.
from a mangled.
Right.
Yeah.
Because when you're looking at it, pediatric kids are resilient, right? So I mean, I'll come back and talk about pediatric trauma, but you'll have a kid coming in where they are talking to you, but the car was badly damaged. So when you look at the picture and the car is badly damaged, but this kid is talking to you, be very careful. Like, this is a kid you definitely want to work up. You want to do a good job. You want to do your due diligence and not just think like, especially if an adult was in the car with this patient and this adult was injured, like, and the car is badly mangled. You want to work them up because kids, like I said, going back to that, they are very different from adults. Yes. Yeah. They may present differently.
So they're not just little adults.
They're not just little adults.
They're still not little adults.
They're still not little adults.
Wait
guys.
today.
We're gonna go out with that too. We're gonna lead in with that. I'm gonna
And
bait her
lead
with
with
that
that.
and get her all fired up, and then we're gonna walk out with.
They're not just little adults.
Anything else on the equipment front? I mean, other than we need the whole battery of weight and age,
I think you guys do a good job of that, yeah.
I think
With the
generally,
service
the color
dosage
coding.
stuff,
We talked about Certidose, of course.
Sort of those,
Certidose, PD
A
bags.
man bringing
Bags.
Certidose
I am
to
a big advocate. I remember our first meeting with Rainbows about that over the phone.
We'll give you
Good.
They didn't think I was crazy, so that was good. But I think safe transportation has come a long way in the ambulance. Like it's being built into the ambulance. We could purchase things that go on the stretcher and equipment, and then the protocol, the pediatric drug tables, and then you've worked with us over the years to really update that for NPAs, OPAs. I mean, just all these different tools. When is that pediatric patient starting to show hypotension? I mean, there's a lot of good tools. So for whatever reason, if you can't find your Broslow tape, PD tape, whatever you want to use, use the protocol is what I would say as well.
Use
There's
the
a lot of good
protocol.
information in there.
Yeah, I don't remember. we talked about this on a previous episode, but just to reiterate, since we're talking about pediatrics, is the downfall from Broslo, from my perspective, is it's for resuscitation, and it's great for resuscitation. But when you are trying to apply that just to a sick kid, none of the information I need is there, right?
Yeah.
The epi, the atropine, all the resuscitation stuff's there, right? What's my Zofran dose? What's my fentanyl
And
dose?
luckily, everything in the protocol is color coded so beautiful.
And I think we talked about this at my shop. We've abandoned that. We've just taken your Certidose tape measure.
Just use it
and we
then go
put
from there.
we put that on those laminated cards that are baked into the protocol, right?
Yep.
And again, every drug that's appropriate for the kid is on the card. Whether it's resuscitation or just an unwell kid, right? And then that column that you were talking about, I think, is probably the most overlooked column in that, is that far right column, and that's all your resuscitation values. When a kid is hypotensive, based on that weight, what a fluid bolus is for that, for that kid. What size Miller blade, what size MAC, what size ET tube, what size, all that stuff's baked in there, right? So it's, that kind of pairing. Again, in my shop, that is, I think, the perfect pairing, and that we've gotten 100%. To, with a broad, a broad swath of information for all our kiddo interactions, right? So
wonderful. Yeah,
all right,
because kids are a lot of calculation, I'll tell you that. So it's definitely easier when you have everything in front of you. Yeah. It's color coded.
And he baited me, so I'll say it. I mean, the one problem, I like the Response Soft product from the perspective that it calculates the dose for you, right? The failing there is it doesn't calculate the volume to draw up.
Okay.
And
that's where the error occurs.
That's where the error is going to occur, right? And yes, I'm biased because the product's mine. The protocol product's mine, if you will. Of course, it's the team's, but
it's about Scott.
It's
I had to tease him. I had to throw in some humor there at the end. Come on.
If they go to the outtakes, they will learn it's only Scott Matters. But yeah, I mean, where the medication error, I mean, that's the thing. It solved half the problem, and I like it for solving half the problem. But
there's still another half.
It's the volume. That's where we're going to make a mistake, is calculating that volume. So
I agree 100%.
Well, that's really getting to the end of our time. We've got at least one thing for you to come back, and we expect you to come back.
Definitely, one or two or three. Definitely, let me know. I'd be happy to. It's my first podcast, guy. My first podcast.
Hey, we appreciate you coming out. This has been great, and yeah. So
I just want to thank everyone for just your willingness, just like the EMS Institute, just for your willingness to just, be supportive of pediatric education and advocacy for kids. I mean, it's been just great that I haven't been kicking and screaming.
Right.
Everyone has been just super supportive and saying,
we know we need this.
Yes, let's do this. And it's just been great. And I just want to thank all the people listening. Thanks for all the work you do for our kids. Definitely.
Well, thank you for everything that you do for us.
Absolutely.
I mean, a lot of that comes from you.
Thank you.
And with that being said, we have a gift.
We do have a gift for you, right?
We have a gift for you for coming on the show.
Oh my gosh, yeah.
So
great.
these are some challenge coins that
Thank you.
the podcast team has manufactured, brewed up.
We minted them. We minted them.
Nice.
So that's kind of a thank you for being our guest today, and we greatly appreciate it.
Thank
and
you.
everything you do for EMS.
But you're only getting one. We're not going to keep giving you coins every time you come back. We're too cheap for that.
2 coins for the live show. 2 coins for the live show.
I look forward to the live show. Definitely.
All right.
That's fun. Yeah.
So, thank you so much.
Thank you. Thank you so much.
Thank you.